The broadcast is now starting. All attendees are in listen-only mode.
Well, hello everyone. We're about to get started with our webinar today. So I'd like to welcome everyone to today's webinar entitled HPV Testing in the Canadian Context, Pros, Cons, and Implementation Challenges, provided by the Consortium for Infectious Disease Control, or CIDC, located in Winnipeg, Canada. My name is George Wertak, Executive Director of CIDC, and I am the organizer of today's program. This educational webinar is made possible with support from Hologic Canada and with assistance provided by BD Diagnostics and Immunize Canada. Today's webinar topic on HPV testing is very timely, as there are many interesting developments in the HPV and cervical cancer diagnostic testing area. One recent activity in this area that you may know about was the development of a document entitled Counseling Patients About HPV Test Results, now available on the CIDC website. And a very current development, just about to be released, is a document entitled Canada's Role in Accelerating Global Elimination of Cervical Cancer. The development of this document was written by some 20 experts on the subject. It was coordinated by CIDC, and with the scientific committee being led by Dr. Mark Krajden, and it will be available soon on the CIDC website. Now in today's webinar, we will learn from lessons gleaned from the important focal trial in BC and how HPV testing was utilized in it, as well as some of the overall benefits and limitations of HPV testing for cervical screening. You can see a list of webinar objectives for this program on the current slide, and these objectives will be addressed during Dr. Krajden's presentation. So this topic is very popular, as nearly 600 healthcare professionals have registered for today's webinar. Our guest speaker for today's webinar is the Medical Director of the British Columbia Centre for Disease Control Public Health Laboratory, Dr. Mel Krajden. Dr. Krajden has a wealth of knowledge on the focal trial and on HPV testing. Our moderator for today's webinar is Dr. Mark Krajden, who serves as chair of the Canadian HPV Prevention Network, and I will pass the microphone over to him in a moment. Please note that this webinar will be recorded, and the recording, as well as the PowerPoint slides, will be made available following the webinar. They will be archived on CIDC's website, and you can see the address at the bottom of the slide on the left hand. CIDC offers a number of useful resources on its website, and included in its programs, it manages the Canadian HPV Prevention Network. This network is a community established to encourage exchanges between medical professionals on areas related to HPV prevention, diagnosis, treatment, and education. If you're interested in joining this HPV network, please send a message via the contact form on the CIDC website, and there's no cost to join this network. I've got just a few housekeeping items to go over. First, all participants who have joined the webinar have joined in listen-only mode. So to ask a question at any time, you can type it in the questions pane and then click on send. You can hear the audio via computer speakers or by telephone. We encourage you to use the computer speaker setting, but if you have trouble with your sound, you can select the telephone button and then dial in with the number and the code that will come up. Questions that you send in will be saved, and all or some of them will be answered following the presentation during the question and answer period. If we do not get through all the questions, Dr. Krajden has agreed to try to find time to answer at least some of them later in writing, and these will be posted on the CIDC website. Again, you can see the address on your screen. Now, once again, the webinar will be recorded, and this recording and the slide set will be available on the CIDC website. And finally, I'd like to request that all participants complete the webinar evaluation. You can see the link for this brief evaluation survey on the screen. It'll only take you about 2 minutes, so please go to it after the webinar. If you registered with your own email address, you will be sent an email following the webinar with this survey link. If you didn't personally register, you should take note of this address so that you can complete the evaluation and then receive a certificate. We greatly appreciate receiving your completed surveys as they help set direction for upcoming webinar topics. I'd now like to introduce the moderator for today's webinar, Dr. Mark Steban. Dr. Steban is the chair of the Canadian HPV Prevention Network, is an associate professor in the School of Public Health at the University of Manitoba, and is a medical consultant with the Family Medicine Group 1851 in Montreal. So welcome, Dr. Steban.
Thank you, George. And hello, everyone. I'm very pleased to serve as moderator for today's program and to be able to work with such a knowledgeable expert of HPV testing as Dr. Mel Krajden. So Dr. Krajden is the director of BC Public Health Laboratory and the medical head hepatitis at the British Columbia Centre for Disease Control. He is also a professor of pathology and laboratory medicine at the University of British Columbia. His clinical research involves hepatitis molecular and health systems research, and his laboratory research focuses on the application of molecular techniques to diagnose viruses, assess correlates between infection and clinical disease, monitor antiviral efficacy, and track microbial infection for epidemiological purposes. This includes serological assay development related to human papillomavirus and extensive clinical trials expertise. He has also been awarded CIHR funding in the fields of human papillomavirus, HIV, and hepatitis C virus. Welcome, Dr. Krajden.
Thank you, Mark, and thank you, George. Good morning or good afternoon, depending on where you are in the country. So I'm going to see if I can control the slides. Do you hear me?
You should be able to, if you can click on the slide.
I just did. Okay, thank you. Well, I've already been introduced, and basically what I'm going to try and talk about is some of the HPV testing issues from a Canadian context. And my disclosures is that I've had grants and contracts to my institution from Roche and Hologic, but have no other issues to disclose. As outlined by George, what I'm going to try to do is explain some of the benefits and limitations of HPV screening to detect cervical cancer, compare the performance of the different HPV tests, and then really outline the lessons learned from the British Columbia randomized focal trial to assess primary HPV testing as part of an organized screening program, and then outline implementation challenges for HPV, including the impact of vaccination, but just going to mention that. Globally, it is a huge challenge in terms of HPV. It's an avoidable disease and associated with gross inequities. And if you looked at 2012, there were more than 500,000 cases of cervical cancer diagnosed, with rates of about 14 per 100,000 globally, but 85% of those rates are in less developed countries, the higher rates. And if you project out for the next 50 years, one would project out 44 million women to be diagnosed with cervical cancer. On this slide, we have the age standardized incidence and mortality rates. So the incidence rates are in blue and mortality rates in red from Canada from 72 to 2004. And As of 2017, there were about 1,500 women diagnosed with cervical cancer, and about 400 died. And what this slide illustrates is the implementation of Pap smearing in the country. And although there's still some declines in the rates of the incidence and mortality, they have largely plateaued. And what I'm going to show you on the next slide is identical data from British Columbia. And really the question becomes, what will it take to make further improvements? And in BC in 2015, we had 179 invasive cervical cancers diagnosed. 70% of them were squamous. 65% of the squamous, 39% of the adenomas. Those women had no screening history or were last screened about greater than 5 years ago. So that's an important challenge, which I will re-emphasize later in this talk. As you know, HPV is the primary cause of cervical cancer, and there's this progression that occurs over years from CIN 1, CIN 2, CIN 3, and then invasive cervical cancer. And what is important to realize is that for these CIN 1, CIN 2, CIN 3, these diagnoses also regress. And below, and it's a little cut off on my slide, are some of the publications that highlight that for CIN 2, the regression rate of around 43% has been noted, for CIN 3 in the 30% range. And clearly the regression depends on the infecting HPV genotype and other host and viral factors. But the important piece is that not all cases of CIN 2 and CIN 3 progress to cervical cancer. This slide is actually a very important slide because it illustrates the evolution from condyloma to cancer. And in red, you see HPV 18. In pink, you see HPV 16. In red, you also see 45 and 56. And there are essentially 14 high-risk genotypes for HPV. And there are others that cause condylomas. And the important point here is that the contribution is not equal. So many of the lower grade lesions are contributed to by the less oncogenic HPV genotypes, and the more oncogenic genotypes, such as 16 and 18, are the major contributors to about 70% of the cervical cancers. And that is important to understand because the HPV test, in some cases, can differentiate the genotype that's infecting the woman, and in some cases, it just says that it's a high-risk type. So when one thinks about screening assays, if you prioritize sensitivity, you essentially reduce the risk of missing an important diagnosis. If you prioritize specificity, you reduce the risk of false positives. And whether that's for a diagnosis or for management, what you're concerned about is the risk of harm is too high. To maximize screening benefits, essentially you need an organized program. An organized program strives to provide the right test for the right person at the right time. In contrast, opportunistic screening, you essentially make do when a patient is seen. This test or the Pap test can be included, but they're not as well organized by achieving a public health reach and access that is optimum. One of the most complex things in understanding the literature is understanding the difference between analytical versus clinical sensitivity and specificity. When one uses a Pap smear, the analytical and clinical sensitivity and specificity are essentially aligned. That's because the PAP is detecting the host tissue response and not per se the inciting agent, which is HPV infection, which is the case in 99.7% of cervical cancers. A single PAP has a sensitivity of about 55 to 60% in general in this country, but ranges have gone between 30 to 87% to detect SIN2, SIN2+. The sensitivity approaches 85 to 90% because multiple tests over time create additional sensitivity from the subsequent tests. The specificity for PAPs for SIN2 and SIN2+ is in the range of 60 to 95% because you're actually seeing the damage to the tissue. And the fact that some of the lesions regress highlights that it's not totally perfect, but it is a very good indicator of the lesions that progress to cervical cancer. The negative predictive value, that is the prediction of if it's negative, is it truly negative, for a PAP is low. And that is because PAPs, as mentioned, are insensitive, dependent on the repeat testing. But the positive predictive value, in other words, if it's positive, is it truly positive, is high because you're actually seeing the damage to the tissue. And as you know, SIN2, SIN2+ are clinically actionable endpoints, usually treated by excision or ablation. Oops. Okay. So for HPV tests, so you should be seeing the slide that says analytical and clinical sensitivity and specificity with HPV tests. For HPV tests, the analytical sensitivity to detect HPV is about 95%. And the analytical specificity is greater than 99%. That is its ability to correctly detect the presence of HPV, the high-risk types. Because most infections resolve within 6 months to 2 years, what really matters is the clinical sensitivity and specificity for SIN2, SIN2+. If you do a single HPV screen, it has a clinical sensitivity of about 95% for SIN2, SIN2+. But its clinical specificity is poor, less than 20%, because most of the infections, greater than 99%, will resolve or won't cause high-grade disease. Hence, the positive predictive value for clinical disease is very poor, probably less than 10%. And this has been reported about a decade ago by Skaruski in the JCLIN Micro in 2012. The age, duration of infection, genotypic oncogenicity, host, and other factors all play a role in that clinical specificity. But the benefits of HPV screening is its higher sensitivity enables earlier SIN2 and SIN2+ detection, and its substantially higher negative predictive value. If it's negative, is it truly negative? If the HPV test is negative, the risk of SIN2, SIN2+ over the next 5 to 10 years tends to be very low, and this enables you to extend the screening intervals safely. So for cervical screening, from that perspective, it's clear that we need a multi-pronged approach. You want to increase vaccine uptake, and I'm not going to talk about that. You want to improve screening uptake, and that will be the focus of this presentation. And ideally, you want to improve treatment, and there's a very good review, and the reference is listed here. If you want to proceed with screening, we can continue with PAPs, but the data suggests we're unlikely to bend the curves further. You can do primary HPV screening, and I'll show you the data from the focal trial. And I think it provides the potential to improve the reach and access, largely because HPV screening allows you to use self-collection, which is a good modality to go directly to the client. You can combine HPV screening with Pap testing, the so-called co-testing. That combination improves the analytical sensitivity slightly because each test's sensitivity is additive, and it improves the clinical specificity because you're able to immediately see if there's damage to the host. But it comes at a much higher cost. So lessons from the focal trial. So BC has had a highly centralized cervical cancer screening program based on conventional PAPs, and it's still conventional PAPs as of today. Back when we were working through the publication for the focal trial, in 2014, there were 460,000 women screened. We have a database registry dating back to 1960. The current guidelines include triannual screening for women aged 20 to 65, but earlier it was biannual screening. And sadly, the screening coverage in British Columbia is about 70% of those eligible, adjusted for hysterectomies. And that is an important point because 30% of those women do not access Pap smears, and about half of the incidence and mortality occurs in those who are unscreened. In terms of the focal trial, if you're wondering where the word focal came from, it is HP, human papillomavirus, testing for cervical cancer screening. The enrollment started in 2008, ended in 2012 with follow-up for 4 years up until 2016. And this whole project took well over 10 years. And the publication in JAMA was published last year. The focal trial objectives were to establish the efficacy of primary high-risk screening, HPV screening in the intervention arm, with liquid-based triage of HPV-positive women versus primary cytology liquid-based screening in the control with HPV triage of ASCUS, atypical squamous cells of unknown significance. The outcome measures were SIN2+ and SIN3+ rates at 48 months, and to determine a safe screening interval for HPV-negative women. The population involved women 25 to 65 from Vancouver and Victoria, British Columbia. Cervical samples were collected in ThinPrep for both cytology and HPV screening, and the test that was used was the hybrid capture for high-risk HPV. Women and providers were blinded to trial arm assignment and enrollment. Cytology and HPV screening occurred at one centralized laboratory. Standardized colposcopy procedures with biopsy was used, and centralized histopathology review blinded to the HPV and cytology results was used. So this figure is terrible, but I still think I needed to show it to you. On the left-hand side, there were 9,552 women in the intervention arm. And if you just look at the circle, the first red circle, they were tested for HPV, and if they were positive, they would go on, if they had greater than or equal to ASCUS, colposcopy. If they were negative, they were rescreened for HPV and with LBC at 12 months. And if they were negative initially for HPV, they were left alone for 4 years. And the second red circle on the column on the left relates to the fact that on exit, they had both HPV and LBC, so co-tested at exit. The middle column in gray represented a safety arm that was later collapsed, largely because there was already good evidence by this time that it was safe enough to do HPV testing and extend the screening interval, and therefore that arm is not going to be mentioned. And then the control arm included 9,457 women, and basically these women had LBCs every 2 years, and on exit, they were co-tested. If you look at the HPV focal trial baseline screen and looking at HPV and cytology rates by age group, on the y-axis, you see the percentage. Red is HPV high-risk positive percentages, and blue, LBC greater than or equal to ASCUS. And what you see is a very consistent higher detection by HPV and a very, very high rate of HPV detection in the 25 to 29 year group. And remember that this is an era when the vaccine had not yet been introduced. On this slide, and part of it is cut off, but essentially what you see in the SIN2, SIN3, you have in blue intervention HPV and in red cytology. And then you'll see for SIN2 plus and a big black circle around it on the left, you see what is the round one detection rate. So round one is entry into the program for the screening focal trial, and 147 were detected by HPV versus 90 for SIN2 plus for control cytology. And then on the right, again in the big black outline, you saw for SIN2 plus 48 detected by HPV and 100 by control for cytology. And this essentially includes the co-test. And I'm sorry, but the slides are not totally aligned, but of the cytology group, 25 cases were detected only by the HPV screen. And of the intervention arm, only 3 cases were detected by the cytology screen. And if you look at the cumulative yield, in blue, there were 147 plus 48 SIN2 plus for 195 detections when you used HPV versus 90 plus 100 equals 190 for cytology. So a very, very similar uptake as part of the organized screening program in this trial. But what we'll illustrate is essentially on the next slide, if you look at the cumulative SIN3 incidence on the box on the left and the cumulative SIN2 incidence on the box on the right, and essentially you can see is with HPV screening in the intervention arm, you always detected the SIN3 and SIN2 earlier in the trial. And then as you go out to the exit where people were co-tested, there was always an incremental yield by doing co-testing because you're improving the sensitivity. And if you look at the next slide, essentially here you're looking at baseline negative participants attending the 48-month exit. And again, on the left, it's SIN3 plus incidence and cumulative SIN2 plus incidence on the right. And what you see is in order to make the detections, the controls were essentially detecting disease that were missed in that first screen by LBC, whereas in contrast, if you look at the intervention arm, women were safe for at least 48 months. And the same thing for SIN2, where again, the combination of using co-testing improved the yield, but essentially the same story, which you needed the additional testing to bring you the sensitivity that the HPV screen brought you from the baseline screen. So what I've illustrated is that HPV is not a magic bullet, but it does detect illness earlier, and in the women who are negative, they can safely have an extended screening interval. One of the questions relates to the amount of colposcopy and the referral rates. And in this slide, we are depicting the round 1 entry and 48-month exit and the cumulative colposcopy rates. So overall, because HPV detects illness earlier, there were higher colposcopy rates earlier on. And then with subsequent screening, the net amount of colposcopy was largely the same because the net yield was very similar. However, if you look at the 25 to 29-year-old group, this is a group that is at low risk of actually having cervical cancer, a group that has high rates of HPV infection. In that group, you had much higher round 1 detection, and as a result of the way the trial was designed, higher colposcopy rates. So in terms of the trial summary, primary HPV screening detected CIN2+ earlier. A negative HPV result had a higher negative predictive value. If you're negative, the probability is it was truly negative for CIN2+ at 48 months than a negative baseline cytology. That's because the baseline cytology is less sensitive. The colposcopy referral rates were initially higher for HPV-based screening, primarily at the baseline screening for women under 30. After 48 months, the screening round, the cumulative number of colpo exams was similar for both arms. The trial was funded by the CIHR. We appreciate the women who agreed to participate in the trial, and the focal study center and lab staff at the BC Centre for Disease Control and the Cancer Agency, and many of them are listed here, were just a fabulous group to work with. So how do the HPV tests compare? So all are about 95% sensitive for CIN2+, and this was already published back in 2012. The QIAGEN, or DiGene, had the lowest specificity because it cross-reacts with some non-high-risk HPV, but it works overall in terms of the 95% sensitivity. The Roche Cobas can type 1618 and detects 12 other high-risk types, and its specificity was slightly better than DiGene, and the Roche is essentially equivalent to the Abbott real-time, which we had a minimum evaluation on. And we also looked at the Hologic Aptima, which looks for messenger RNA. It types 16, 18, and 45 and detects 11 other high-risk types. And it had a slightly better specificity for high-grade lesions, largely because it probably targets the viral E6 and E7 oncoproteins, which are necessary for malignant transformation. The overall sensitivity was the same in the evaluations, and then the publications are listed below for the hybrid capture versus the Roche and the Aptima assays. Why should Canada transition to primary HPV screening, and what needs to be in place to optimize outcomes? So I'm showing you this slide again, where we have essentially plateaued with the rates of incidence and mortality from cervical cancer. So who is being missed? And I'm coming back to this important thing. So in BC in 2015, we had those 179 cases, 70% squamous, 65 of the squamous and 39% of the adeno cases had no screening history or were last screened greater than 5 years ago. So if you want to improve that curve, you have to address the population who is now not being reached. If you look at the Canadian Partnership Against Cancer, what they have done is an analysis of the rates of women aged 25 to 69 reporting at least one Pap test in the past 3 years. And those rates vary by part of the country from a low of 71.4% to a high of 85.1%. And then if you delve deeper and you look at those who are socially and materially deprived, the uptake of Pap testing was about 12% lower in those most socially and materially deprived. So if you think about increasing the screening uptake, what I've illustrated to you is that the incremental yield of primary HPV screening in the focal trial was small. It clearly enabled earlier SIN2, SIN2 plus detection. It allowed you to extend screening intervals for those who are HPV negative. And I haven't shown the data, but there is some data, not great data, but it improves adenocarcinoma detection. So an outstanding gap is improving screening reach and access. And the benefit of HPV screening is that it enables self-collection. So I'm not going to go into this into detail, but Arbin has recently published a meta-analysis of self versus clinician collection. Using PCR-based HPV assays, self-collection was as accurate as clinician samples. Offering self-collection kits is generally more effective than sending clinic-based screening invitations. Response rates are highly variable amongst the different settings, but screening uptake increased by up to 4-fold, and that's been published in various different locations around the world. Self-collection is only possible if HPV screening is used. Self-collection won't work for cytology or for cytology triage. You could try triage with genotyping, the high-risk genotypes like 16 and 18, or you can do methylation, which I'm not going to discuss, but methylation studies are relatively limited and there is variability in the various studies that are out there. BC is in the process of a self-collection for HPV screening pilot. It's at cervixcheck.ca, and with a focus on underserved South Asian and First Nations populations. In terms of triage, for HPV screening, you still need a triage process, and that could be cytology with P16, Ki67 immunostaining. It could be cytology with genotyping for the 16, 18, 45 perhaps. It could be genotyping alone. And as mentioned, methylation may be suitable for triage of self-collected samples because it basically looks for methylation in the DNA. Below are some potential triage management algorithms for HPV screening. So if you have an HPV positive, you could do the HPV genotyping. And if it's 16, 18, refer to colposcopy. Otherwise, you can do cytology, look for greater than ASCUS, decide whether you do colposcopy immediately or delay it and retest for HPV 12 months later. Similarly, you could do reflex cytology, again, look for ASCUS and decide whether you go immediately to colposcopy or do the HPV test 12 months later. So improving reach and access is a very important component. So if you're going to switch to HPV, you're going to need a registry to remind physicians and or women to be tested. And a good example is the Scottish cervical call or recall system, and I've given you a link to that system. If you have longer screening intervals, it creates benefits and risks, and it's really crucial that the client be engaged directly. Rolling out self-collection is a mechanism of improving screening uptake, and the CervixCheck.ca of online self-testing is an example. You still need to think very carefully about the underserved populations, vulnerable populations, indigenous populations, and immigrants who do not avail themselves for testing, and yet might be willing to avail themselves for self-collected testing. Other considerations. As the vaccinated cohort reaches screening age, the 4-valent Gardasil, which will address about 70% of cervical cancers, and the 9-valent vaccine from Merck will address about 90% of the high-risk oncogenic types. These will profoundly impact screening programs, particularly for younger women. And cytology will have limited value, and the value and frequency of HPV testing will need to be reassessed as this cohort of vaccinated women go through the system. If you look at most of the business cases, there is a hump of increased costs to shift to HPV technology, followed by lifetime cost savings. But you also have cytology staff that are aging and needing retraining. And you need to think very carefully about putting resources into improved screening uptake, and these have been discussed. I want to show you this slide from McCulloch, just published in the Medical Journal of Australia. So Australia has been aggressively vaccinating its women, started, I believe, in 2007, and they have just switched to primary HPV screening. And this is the report on the first 6 months after implementing HPV screening. And in this case, they're reporting on 150,700 women who've had primary screening, and they are recommending a 5-year cycle of screening for those who are HPV negative based on the international data. And with the first blue arrow, you see that if you look for any oncogenic type, there are still high rates of any oncogenic type in younger women. But you can see the downturn in HPV 16 and 18 in the second arrow in the middle box, where you can see the impact of the vaccination of women and how this is going to profoundly change the interpretation of the Pap smear. So if I just try to summarize here, on the next slide, you have a World Health Organization life course approach to cervical cancer control, and some of it pertains to Canada, and that is trying to vaccinate as many of the women and boys as appropriate, to think about new ways to improve access and reach to cervical screening, and then having very rapid triage processes to engage them into care, in colposcopy when that's necessary, and of course to think about improvements in tertiary prevention. So in conclusion, HPV screening detects SIN2, SIN2+ earlier, and if negative, enables extended screening intervals in the 5-year range. It enables self-collection, which is likely to increase screening uptake. The implementation will require efforts to directly engage with women to ensure effective screening uptake. And it is time to retire the Pap test as a screening tool and use it as a triage tool. And then I just have some references for you. Thank you.
Thank you, Dr. Krajden, for providing a very interesting overview of the FOCAL project and of HPV testing in general. I will look if there are questions that are being already typed. So for those people that want to ask questions to Dr. Krajden, please fill the panel, the box at the panel on the right side of the screen. So if you have any question, send them. We will now move on to question and answer period. I'm not seeing question at this moment, so I have a few questions, Dr. Krajden. You've talked about self-sampling. Would that mean that cervical cancer now will go like a mail-in type of screening?
It could. I think one of the things, if you look at the way the world of diagnostics is moving, for those individuals who have the wherewithal and the supporting infrastructure to choose what are appropriate screening testing, then those screening services can be provided basically through different modalities. So it could be a mail-in procedure, it could be a online program. And what has to really think about, not only how do you provide the service to the individuals who have the wherewithal, but how do you better support vulnerable populations who don't avail themselves for these services. And so thinking very carefully about the kind of service options you provide for women who don't have access, who are remote and rural, and or may be immigrants and don't understand the implications of being tested. So it's really about coming up with a package of different services, but always trying to evaluate the efficacy of the uptake, the screening efficacy, and the implications on the health.
So we have a question coming in lower income, resource constrained settings where you may only have the option to offer older women. Would HPV self-testing be of help?
So I think that it would be of help. And, you know, based on the literature, being able to identify whether or not they have a more invasive genotype, 16, 18, 45 perhaps, depends on the jurisdiction, then the self-test needs to be linked, or self-collection needs to be linked to how that woman gets the services they need. So I think that that would make sense. And there are, for example, point-of-care services that could be provided in some communities. It's really about thinking about moving the testing to the person, but making sure that you have the evaluation pieces in place so that you're always able to assess, are you reaching the people? Are you providing an accurate service? And are they being engaged into care?
I have a technical problem. Okay, I see now for the questions. What strategies are there for increasing vaccine uptake?
That's probably the toughest one. It's clear that in British Columbia, we still sit around 60 to 70% uptake. And in certain parts of the country, like Newfoundland, the uptake is very high, and in Quebec. So I think part of it is similar to the vaccine challenges we face globally for not only HPV, but other things, is we need to be much more effective at dealing with the anti-vaxxers, and then thinking carefully about the impact of vaccination, because the impact of vaccination goes far beyond cervical cancer. It'll reduce some of the anogenital cancers, it'll reduce some of the oral pharyngeal cancers, and there needs to be very strategic approaches to try and improve uptake of vaccination. And as you know, Mark, there are efforts to not only reduce vaccination from the 3 to 2 doses, but also potentially to see whether 1 dose, given at the right time in one's life, could be sufficient to protect the individual from acquisition of high-risk HPV oncogenic infection.
There's a question about when can a sexually inactive female stop getting Pap test?
Yes, so typically, if you look at Pap tests, typically if there's been a negative history in the past, multiple tests, and they're negative, then 2 or 3, typically maybe more than 2 or 3, may be enough. But again, it really depends on what was the past history. If you look at the literature, although HPV totally resolves clinically in 6 months to 2 years, it is entirely possible if they're immunosuppressed, may have been exposed in the past, it's not totally clear that the virus totally disappears. So really it depends on, do they have negative multiple paths that are negative? Do they have no other past risks for having had HPV? Are they not immunosuppressed? In which case, typically, the current recommendations are stopping around 60, 65, but it really depends on the population.
Thank you for the answer. So another question, how do the various triage methods, specifically HPV 16/18 versus pap smear, affect the sensitivity and specificity?
So I always struggle with this notion that people have to remember that there's the analytical sensitivity of the HPV test, and that's fabulous. So in other words, you're looking at a 95% sensitivity to detect the HPV and probably a 99% specificity to detect HPV. In terms of the clinical specificity, a lot of it depends on the triage process. So in other words, do they have evidence of a high-grade lesion or not? And if they have evidence of a high-grade lesion with 16 and 18, then that increases the probability that this is something that might need to be addressed through excision or ablation. On the other hand, if they don't have 16 and 18, then what does the lesion look like from a cytology perspective? And then the probability, if it's a lower grade lesion, then you might be able to follow the individual for that regression.
We have another question. I'm curious what form of HPV self-testing you are advocating. My experience with self-collection by experienced patient in my own clinic showed HPV self-testing to not be as accurate as suggested in a clinical trial setting, leaving me uncomfortable recommending this to my patients.
I think that there needs to be more work on self-collection. Currently, some of the approaches have been using dried swabs, and dried swabs don't stabilize the HPV as well as other mechanisms of stabilization. And I think you need to also think about the context. So if you have a woman who's not going to be tested, and you can make sure you put in the quality assurance processes that self-testing is done reliably, then you will increase the net detection yield by improving reach and access. So it's really about trying to study this carefully to assure that the collection is accurate. And then one of the things you can do is measure whether or not cells have been collected, because you can look for endogenous targets like beta globin, and you could be assured that a sample has been collected, and that can also help assure that the sample has been correctly collected. But I'm sure that this kind of process needs a lot more work, a lot more strategy, and then figuring out the different vulnerable communities. How do you reach them and have them engaged into self-collection if that's what they want?
There's a question about cost between HPV testing and LBC. Is there a significant difference?
The challenge with some of the costing is you never know what the net cost that you're going to get. If you have a large centralized program, the net cost for the testing can be reduced. So I'd rather not get into the details of the cost, but if you look at all of the cost measures, remember that if you're looking at women greater than age 30, you can basically take a substantial proportion, probably more than 90% of those women can extend their screening intervals. So you need less cytologies, less cytological technologists, And so you have to carry the cost over multiple time intervals and amortize it so that you're not focused only on the cost of the implementation, but the long-term life course cost. And thinking carefully about the fact that 30% of women in British Columbia are either not tested or under-tested. So if you can increase the testing in that population, you're moving the needle in the right direction.
There's a question about, I would like to ask, is it mandatory to genotype for high risk 16 and 18, even after high risk positive HPV in regard to treatment?
I don't think it's absolutely mandatory to test for 16 and 18. What's clear is you have to recognize that if you're going to use cytology as your triage, then remember that the sensitivity of the triage is in the 60% range in a good program. So that means that you might need to retest them later if they have less than or equal to ASCUS. And so really, it's really about how do you triage the person? And is there an incremental benefit of using immunostaining? Is there an incremental benefit of using methylation? Or are you just going to use the cytology? From the best I can glean from the literature, if you repeat the cytology enough, you'll get the information you need in terms of what the next step should be.
Thank you. Unfortunately, that is all the time we have for questions. So I would like to thank Dr. Krajden for an excellent presentation and discussion around the questions from our audience. It has been a pleasure working with you on this educational webinar, and I will now pass the microphone over to George for closing comments.
Okay, thank you very much, Dr. Krajden and Dr. Steban. That was very interesting. I'd like to thank you both for taking time out of your very busy schedules to be with us today and for your support of CIDC's continuing medical education series. CIDC very much appreciates the support of its partners who allow us to bring this webinar to you at no cost. Those are Hologic Canada, BD Diagnostics, and Immunize Canada. Now, to our audience members, please note that this webinar has been recorded, and the video recording and the slide set will be available on the CIDC website. Remember that the two recent documents I had earlier mentioned on cervical screening and HPV are available on the CIDC website. And they're entitled Counseling Patients About HPV Test Results and Canada's Role in Accelerating Global Elimination of Cervical Cancer. So we also encourage you to join the Canadian HPV Prevention Network, a free network of interested clinicians, researchers, educators, and others who are interested in HPV control issues. Now you can join this network by sending a message in the contact form on the CIDC website. Now watch for an announcement about our next webinar, which is scheduled for September. CIDC appreciates the input from our participants who suggest future webinar topics. Please remember to complete the evaluation form by clicking on the link in the follow-up email that you will receive shortly. So thanks very much for your interest in CIDC webinars. We'll be back in September, so please enjoy the summer. Thanks and goodbye.